Friends, in this video, I'm going to give a quick explanation of the Chang Analysis page that we generate from the iTrace. And in fact, if you understand this page, you will understand the other reports that the iTrace generates because they are very closely interrelated. Now, on the top left, you see the higher aberrations from the internal structure of the eye, which is basically the lens. And here at the bottom you will find the higher aberration values of the cornea, and in the middle you will find the higher aberrations of the total eye, that is the cornea plus the lens. Right now, when you see these bars, remember no bars is good, and the bigger the bars are, more the higher aberrations of the patient, regardless whether it is red in color or blue in color. Bars are not good, as simple as that. Right now, what do you see in terms of this numbers over here? If you see these numbers here, third, fifth, sixth, so they're related to the aberrations or the higher aberrations of the Zernike polynomials. And if you see over here, this is the Zernike polynomials. It starts with the orders: 0 order, 1 order, 2, 3, 4, 5, and it goes like this. And that is what is actually, you have it over here. I mean, the orders are listed over here. Now, the lower order aberration is this column over here, which is the second order aberration of the Zernike polynomials. And this is the defocus or the myopia hyperopia, followed by the vertical astigmatism and horizontal astigmatism. What you are seeing in this place over here are the aberration values, the higher order aberrations. That means aberrations that starts from the third order, right? So here, I mean third, fourth, fifth, sixth. So these aberrations are actually listed over here for the human crystalline lens, for the cornea, and then for the total line. As you can see over here, for the lens, there is quite some aberrations over here: coma, trefoil, astigmatism. For the cornea, other than astigmatism, there's not much of aberrations over here. So for the total eye, whatever aberration you are seeing is mainly the product of the human crystalline lens. So in this way, you can take a decision whether you will be implanting the premium lens for these patients, like a diffractive multifocal IOL. Because if this total eye aberration values were mostly from cornea, then it would not have made any sense for the patient, right? But because these aberrations are coming from the lens, and with the cataract surgery, the human crystalline lens is thrown out, you could well consider this patient for a premium lens. Now, coming to the top right over here, you see the total higher order aberration values over here. And it is 0.49 for this patient. Anything less than 0.5 microns, I believe, would be good. Try to see that the patient's higher order aberration values are less, at least less than 0.5 microns, right? And then you see at the bottom over here the three most important higher order aberrations that actually brings down the patient's vision are the coma, the spherical aberration, and the trefoil, and their individual values are listed over here. Try to see that the coma, spherical aberration, trefoil, each of these aberrations values are less than 0.2, and that would be good for the patient if you are selecting the patient for premium IOL. Then you have the angle alpha over here. Angle alpha is the difference between the visual axis and the optical axis. If the angle alpha values are very high, many surgeons think that the lens will not be sitting close to the visual axis, and that patient may not be happy with a diffractive multifocal IOL. And the bottom over here, you will see the steep and the flat meridians and the astigmatism value. But what is the effective RP? Effective RP is the effective real power of the cornea. And below it, you find the central radius / power. That is, you get the radius of curvature values as well as convert it into the power values. Now, if you have to compare the IOL, if you have to compare the keratometry readings that you get from the IOL Master or Lenstar or any other keratometry machine, then you have to compare the values with the iTrace. Then you should look into this value over here, because this is more of a simulated keratometry value. And you get this value by measuring the anterior cornea, like the keratometers measure the anterior cornea, and you get a total power of the cornea by applying the fictitious keratometry index of 1.3375. So you measure the anterior cornea and get the total corneal power by not measuring the posterior cornea and taking into account the keratometry index of 1.3375. So if you are relating your values from the Lenstar or any other keratometry machine with the iTrace, then this is the one that you should always compare with, right? Now, this is based on a normal anterior posterior ratio of 82%, right? Now, if the patient has gone through a LASIK surgery, then the patient's effective real power and the simulated corneal power will actually not match. These two will not match. Why? Because the effective real power is basically measuring the anterior cornea and the posterior cornea, taking into account the true refractive index of the cornea, which is 1.376, and the true refractive index of the aqueous. Why am I talking of the aqueous? Well, you will understand this more if you go into my website and look into this, which actually explains you how this total corneal power or the net corneal power is actually calculated. Now, because for post-LASIK patients, their normal cornea anterior posterior ratio is altered, therefore you will find a lot of discrepancy between effective real power values and the simulated keratometry values over here. Next, you get the corneal spherical aberration values over here. And this patient has a positive corneal aberration, spherical aberration. So a negative spherical aberration will actually, a lens with negative spherical aberration may benefit this patient. And last, you have the IES axis power. What do we mean by that? Well, in topography machines also you will find this. By IES axial power, what we are meaning over here is that in this central part over here, what is the difference of power between the superior and the inferior, right? And normally this difference is less than 1 diopter for normal patients, right? For the pentacam, if the inferior is more than the superior by more than 1.5 diopters, or the superior is more than the inferior by more than 2.5 diopters, then that patient's cornea is regarded as an abnormal cornea, right? So this power, this difference between the superior and the axial power is actually noted over here. So this is an axial map over here, and you find a lot of values, that is 0, 1, 2, 3 millimeters, 0, 1, 2, 3 millimeters. How do you use these values? So if this patient has gone through a post-LASIK, is a post-LASIK patient, then you can actually go into the ASCRS website for the calculation of IOL power, and you can put in the 0, 1, 2, 3 millimeter values over here. You can also put the effective real power of the iTrace here in this column over here, and get the power of the lens of the IOL, right? I hope this video has been useful to you. Thank you very much.